Welcome. Today we will talk about Entamoeba histolytica and amoebic dysentery. Protozoa are microscopic, single-celled organisms. The classification of protozoa of medical importance is primarily based on their morphology and mode of locomotion. The classification of protozoa of medical importance is as follows. 1. Sarcodina amoebae. These protozoans move by pseudopodia. An example is Entamoeba histolytica. 2. Mastigophora flagellates. These protozoans move via flagella. An example is Trichomonas. 3. Ciliophora ciliates. These protozoans move with the help of cilia. An example is Balantidium coli. 4. Apicomplexa sporozoa doesn't have a specialized organ for locomotion. An example is Plasmodium. The parasite's name is Entamoeba histolytica and the disease name is Amoebiasis. The name Entamoeba histolytica is derived from Greek roots, ent meaning inside or within, indicating the parasite's habitation within a host. Amoeba, meaning change, referencing the organism's shape-shifting ability. Histo meaning tissue. Lytica meaning dissolution. Entamoeba histolytica translates to an amoeba that dissolves tissue. Entamoeba histolytica is globally distributed. Endemic in low socioeconomic areas. Highest prevalence in tropical and subtropical climate. 50 million symptomatic cases yearly, leading to 100,000 deaths annually. The life cycle of Entamoeba histolytica involves 3 key stages: trophozoite, precyst, and cyst. Each stage has distinct morphological and functional characteristics. 1. Trophozoite stage. Morphology. Trophozoites are active, motile, and irregularly shaped, measuring 10-60 micrometers in size. The cytoplasm is divided into ectoplasm clear outer layer and endoplasm granular inner layer. The cytoplasm exhibits finger-like pseudopodia for movement and capturing food. The endoplasm contains food vacuoles for digestion, ingested white blood cells, ingested red blood cells, and a nucleus with a central karyosome and peripheral chromatin. The trophozoites inhabit the lumen and wall of the large intestine. The trophozoites may invade the wall of the large intestine and reach many organs. 2. Precyst stage. Morphology. Before encystment, trophozoites extrude their food vacuoles and adopt a round or ovoid shape. This is the precystic stage. Function. Precysts prepare for encystation by secreting a refractal cyst wall. This stage is transitional and occurs in the intestinal lumen. 3. Cyst stage. Morphology. Mature cysts are spherical, 10-20 micrometers in size, with 4 nuclei. Early cysts may have chromatoid bodies, cigar-shaped refractal structures, and glycogen mass, which serves as an energy reserve. Both chromatoid bodies and glycogen masses typically disappear in mature cysts. These cysts are only formed within the intestinal tract but can survive in the external environment. Cysts are non-motile, non-feeding, and serve as the infective stage. The outlines of the Entamoeba histolytica complete life cycle are: 1. Infection begins with the ingestion of mature cysts via contaminated food or water. 2. The cyst wall protects the parasite from the acidic environment of the stomach, allowing it to reach the small intestine. 3. Excistation occurs in the small intestine due to the alkaline environment. The cyst wall breaks and each mature cyst releases 4 trophozoite. 4. The trophozoites migrate to the large intestine and multiply by binary fission. 5. Trophozoites, if not invading the intestinal mucosa, travel down the colon, dehydrate, and undergo encystation. Trophozoites transform into precysts and then into cysts, causing asymptomatic infection. 6. Cysts are excreted in feces and can infect new hosts. Trophozoites and precyst disintegrate quickly outside the body. 7. In some cases, trophozoites invade the intestinal mucosa, leading to symptomatic disease. This invasion is facilitated by enzymes secreted by the trophozoite. 8. Invasions may be intestinal or extraintestinal. Intestinal invasion. This leads to amoebic dysentery, colitis, and appendicitis. Extraintestinal invasion. Trophozoites can spread through the bloodstream to other organs, most commonly the liver, lungs, brain, and other tissues. Overview of Entamoeba histolytica life cycle. Habitat: cecum and sigmoidorectal region of large intestine. Definitive host: only humans know reservoir host or intermediate host. Infective stage: mature quadrinucleated cysts. Mode of transmission: ingestion of mature cysts through contaminated food and water through 1. Fecal oral route. 2. Person-to-person contact, direct transmission via hands and poor hygiene. 3. Sexual transmission occurs, especially through anal-oral contact. Pathogenesis and virulence factors. 1. Adhesion molecules allow trophozoites to attach to host cells and tissues, initiating infection. 2. Contact-dependent cytolysis, direct killing of host cells upon contact, primarily mediated by amoeba pores proteins that form pores in host cell membranes, causing lysis. 3. Proteases, enzymes that break down host tissues, aiding invasion and immune evasion. 4. Hemolysins, proteins that lyse red blood cells, increasing tissue damage and providing nutrient. 5. Phagocytic activity, trophozoites actively engulf and digest host cells and bacteria for survival. Summary of pathogenic mechanisms. The image categorizes the pathogenic mechanisms of an infection into 3 main stages. 1. Cellular invasion. The pathogen colonizes the colon and penetrates the mucus layer to access host cells. It modifies mucus secretion, adheres to host cells, and erodes tissues. It also modulates the immune response and induces cell death. 2. Extracellular matrix invasion. The pathogen strengthens attachment using adhesion plaque formation. It secretes cysteine proteases to break down extracellular matrix proteins. It deactivates host immune molecules. 3. Dissemination. The pathogen spreads to the liver via portal circulation. It causes liver damage. It further disseminates to other organs, including the lungs, brain, and skin. This image illustrates the intestinal pathology of Entamoeba histolytica. 1. Flask-shaped ulcer, a characteristic lesion where the parasite breaches the mucosa and spreads laterally in the submucosa. 2. Sinus formation, tunneling ulcer extensions that can lead to further tissue destruction. 3. Deep ulceration extends beyond the muscularis mucosae into deeper layers. 4. Perforation, severe damage may cause a hole in the intestinal wall, leading to peritonitis. 5. Amoebioma, a localized granulomatous mass formed due to chronic inflammation, sometimes mistaken for tumors. 6. Blood vessel invasion leads to systemic spread of the parasite, potentially causing liver abscesses. The immune response to Entamoeba histolytica involves both innate and adaptive immunity to control infection and prevent tissue damage. 1. Innate immunity. Physical and chemical barriers. The mucus layer in the intestines and the acidic environment of the stomach serve as the first line of defense against Entamoeba histolytica. Pattern recognition receptors. Toll-like receptors on intestinal epithelial cells detect pathogen-associated molecular patterns in Entamoeba histolytica. TLR2 and TLR4 are crucial in recognizing the parasite and initiating an immune response. Cytokine production. Intestinal cells release pro-inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha, which recruit immune cells to the infection site. Neutrophils and macrophages. Neutrophils and macrophages quickly move to the infection site and attempt to phagocytose and kill the parasite. Macrophages generate reactive oxygen species and nitric oxide to destroy Entamoeba histolytica trophozoite. 2. Adaptive immunity. Cell-mediated immunity. Cell-mediated immunity is the primary defense against Entamoeba histolytica, influencing disease severity, recovery, and protection against reinfection. Role of T cells. CD4 plus T helper cells play a crucial role in coordinating the immune response. Th1 cells produce IFN gamma, activating macrophages to enhance their amoebicidal activity. Th2 cells produce IL-4 and IL-10, which have a regulatory role and help in antibody production. CD8 plus T cells and cytotoxic T lymphocytes contribute to parasite clearance. Neutrophil response. Neutrophils infiltrate infection sites rapidly but can contribute to tissue damage in amoebic colitis. Humoral immunity against Entamoeba histolytica. Coproantibodies and serum antibodies dynamic. Coproantibodies are detected in 80% of amoebic dysentery cases but declined to 55% over week. Serum antibodies increase during this period, indicating systemic immune activation. Antibody response in invasive amoebiasis develops within a week and persists for years but does not prevent reinfection or aid healing. IgM and IgG are produced, with IgG2 as the dominant subclass. Mucosal barrier reinforcement. Secretory IgA in the gut prevents Entamoeba histolytica adhesion to intestinal cells. Defensins and cathelicidins enhance the mucosal barrier, reducing parasite colonization. Evasion of immune response by Entamoeba histolytica. 1. Capping mechanism. Clusters and sheds surface-bound antibodies to evade immune detection. 2. Cysteine proteases. Degrades host immune molecules, including antibodies and complement proteins. 3. Galin-C-lectin. It is a key surface adhesion molecule in Entamoeba histolytica. It facilitates parasite attachment to host cells. Inhibits complement-mediated lysis, preventing immune destruction. 4. Amoebopores. Pore-forming peptides that lyse host cells, aiding tissue invasion. 5. Antigenic variation. Alters surface antigens to avoid recognition by the host immune system. 6. Immune suppression. Modulates host immune responses, reducing inflammation and immune activation. Diagnosis of Entamoeba histolytica infection involves a patient's travel or residence in endemic regions, raising suspicion, assessing the clinical picture, and conducting investigations to confirm the presence of the parasite. Amoebiasis can be presented as an asymptomatic infection, intestinal amoebiasis, or extraintestinal amoebiasis. The clinical picture of amoebiasis varies depending on the severity and site of infection. Asymptomatic carriers or asymptomatic cyst passers, making up 90% of infected individuals, shed cysts in their stool without symptoms and serve as a source of infection. Intestinal amoebiasis presents as amoebic dysentery, characterized by abdominal pain, diarrhea with blood and mucus, flask-shaped ulcers in the colon due to trophozoite invasion. Tenesmus. Persistent and painful desire to evacuate the bowel despite having an empty colon. It occurs when the sigmoid rectal region is affected. This image displays flask-shaped ulcers, 3-5 mm in size, with hyperemic borders and a necrotic base. Intervening mucosa is normal, indicates that the lesions are localized, with the mucosa between them appearing normal. Diarrhea is defined as the frequent passage of soft or liquid stool. The image depicts a flowchart categorizing diarrhea based on its type and associated symptoms. Types of diarrhea and causes. 1. Watery diarrhea. Associated causes: virus, vibrios. 2. Mucoid diarrhea. No fever, giardia. Fever, shigellosis, campylobacter. 3. Bloody diarrhea. No fever, Entamoeba histolytica. Fever, shigellosis, campylobacter. This image is a comparative illustration of amoebic dysentery and bacillary dysentery, highlighting differences in their causative organisms and pathology. 1. Amoebic dysentery. Organism detected: Entamoeba histolytica cyst or trophozoite. Pathology: ulcers, deep. Intervening mucosa, normal. 2. Bacillary dysentery. Organism detected: bacteria Shigella. Pathology: ulcers, shallow. Intervening mucosa, inflamed. This image elaborates on clinical and stool characteristics. Clinical features: amoebic dysentery. Slow onset, absent fever and toxicity, localized abdominal tenderness. Bacillary dysentery. Acute onset, fever and toxicity present, generalized abdominal tenderness. Stool characteristics: amoebic dysentery. Frequency of 6-8 times day, offensive odor, dark red color, feces mixed with blood and mucus, non-adherent consistency, few pus cells. Bacillary dysentery. Frequency over 10 times day, no odor, bright red color, blood and mucus with little or no feces, adherent consistency, numerous pus cells. Complications of intestinal amoebiasis. 1. Fulminant amoebic colitis. Generalized necrotic involvement of the entire large intestine. Commonly occurs in immunocompromised patients and during pregnancy. 2. Amoebic appendicitis. Inflammation of the appendix caused by Entamoeba histolytica. 3. Intestinal perforation. Rupture of the intestinal wall due to severe ulceration. 4. Amoebic peritonitis. Infection and inflammation of the peritoneum resulting from intestinal perforation. 5. Perianal skin ulcers. Ulcers that extend to the perianal skin cause localized discomfort and infection. 6. Amoeboma amoebic granuloma. Formation of a granulomatous mass, typically located in the rectosigmoid region. 7. Chronic amoebiasis. Long-term complications include thickening, fibrosis, stricture formation, and scarring of the intestinal wall. Extraintestinal amoebiasis. Mechanisms of dissemination. Extraintestinal amoebiasis occurs when Entamoeba histolytica trophozoites disseminate beyond the intestinal tract. The primary mechanisms of dissemination include: 1. Intestinal invasion. Entamoeba histolytica trophozoites invade the intestinal mucosa, causing tissue damage and inflammation. This invasion disrupts the mucosal barrier, allowing trophozoites to enter the bloodstream. 2. Hematogenous spread. Route. The most common site for secondary infection is the liver, primarily due to the portal vein system draining blood from the intestines into the liver. This hematogenous spread allows trophozoites to establish amoebic liver abscesses. 3. Direct extension and contiguity. Spread. In some cases, trophozoites may spread directly to adjacent organs. For example, an amoebic liver abscess can rupture through the diaphragm, leading to secondary amoebic lung abscesses. Lymphatic spread. Less common. Extraintestinal amoebiasis, particularly hepatic amoebiasis, involves infections outside the intestines, with the liver being the most common site affected. 1. Amoebic hepatitis. Diffuse inflammation. This condition involves a diffuse inflammation of the liver. Symptoms. It typically presents with an enlarged and tender liver, accompanied by pain in the right hypochondrium. Amoebic liver abscess. Symptoms. Common symptoms include weakness, anorexia, and a slight fever. Tenderness in the right hypochondrium is typical. Characteristics. The abscess contains thick, chocolate-brown pus often described as anchovy sauce pus, which is liquefied necrotic liver tissue. This pus is typically free of amoebas and bacteria. At the periphery of the abscess, normal liver tissue may contain invading amoeba. Complications. Untreated abscesses can rupture into adjacent tissues such as the peritoneum, pleura, or pericardium, leading to severe complications like peritonitis or pleural effusion. 2. Pulmonary amoebiasis. Pulmonary amoebiasis is a serious complication of amoebiasis, often resulting from the extension of an amoebic liver abscess or, less commonly, through hematogenous spread. It typically affects the lower part of the right lung. Symptoms: chest pain, severe pain in the lower chest, often radiating to the right shoulder. Dyspnea, difficulty breathing. Expectoration, coughing up chocolate brown or anchovy sauce, colored sputum, especially if a bronchohepatic fistula forms. 3. Peritoneal amoebiasis. It occurs when an amoebic liver abscess ruptures into the peritoneal cavity or when there is perforation of the cecum. Symptoms: abdominal pain, sudden onset of severe, generalized abdominal pain resembling septic peritonitis. 4. Pericardial amoebiasis. The most serious complication of amoebic liver abscess occurs in less than 1% of cases. More common with abscesses in the left lobe of the liver. Abscess perforation leads to progressive tamponade or sudden shock. 5. Genitourinary amoebiasis. Genitourinary amoebiasis is rare and can occur through direct spread from the perineum or anal intercourse. Symptoms include painful ulcers with discharge. It affects the prepuce glands, vulva, vagina, and cervix. 6. Cutaneous amoebiasis. This results from the perforation of an abscess or intestine into the skin. 7. Amoebic brain abscess. Amoebic brain abscess is a rare but severe complication of amoebiasis, leading to significant destruction of brain tissue and death. Laboratory diagnosis. 1. Stool analysis. Direct wet mount. The saline wet mount may show motile trophozoites with RBCs. Requires fresh stool. Limited sensitivity. Concentration technique. Used to detect cysts in stool samples. Increases the chance of detecting E. histolytica. Permanent stain smear. Stains, trichrome. Essential for differentiating protozoa in the stool. 2. Antigen detection. The antigen is the galactose N-acetyl D-galactosamine-specific lectin, often referred to as the gal-NAC lectin antigen. Types of samples. Stool, serum, and liver aspirates. Fresh or frozen stool is required. Formalin fixed samples may interfere with some tests. 2. Methods. Enzyme-linked immunosorbent assay. Immunochromatographic rapid test. Monoclonal antibody-based test. Antibody detection. 1. Types of sample. Serum. 2. Methods. Indirect hemagglutination assay detects IgG antibodies. Enzyme-linked immunosorbent assay. Indirect fluorescent antibody test. Immunoblotting Western blot. 4. Molecular detection. 1. Sample type. Stool, liver aspirates, blood and tissue biopsy. 2. Methods. Polymerase chain reaction PCR gold standard for detecting E. histolytica DNA. Real-time PCR. 5. Endoscopic biopsy, sigmoidoscopy, colonoscopy. Procedure. Biopsy taken from at least 6 areas of the affected mucosa. Ulcer edges are the preferred site for detecting Entamoeba histolytica trophozoite. Findings. Flask-shaped ulcers. Mucosal necrosis, inflammation, and trophozoites in tissue. Stains used. Hematoxylin and eosin identifies trophozoite. In this video, we observe a live, moving trophozoite of Entamoeba histolytica. The image illustrates Entamoeba histolytica infection, showing trophozoites with ingested RBCs, a flask-shaped intestinal ulcer, and an amoebic liver abscess. Treatment: amoebicidal drugs. 1. Luminal amoebicides, such as diloxanide furoate. They act on Entamoeba histolytica in the intestinal lumen. 2. Tissue amoebicides, such as metronidazole, tinidazole, nitazoxanide. They are effective in the treatment of invasive amoebiasis. Asymptomatic intestinal carrier. First choice: diloxanide furoate 500 mg 3 times a day for 10 days. It is not well absorbed systemically. It remains in the intestinal lumen, making it ideal for eliminating asymptomatic cyst carriers. Interferes with protein synthesis of Entamoeba histolytica. Intestinal infection. First choice: metronidazole followed by diloxanide furoate. Metronidazole inhibits the nucleic acid synthesis of Entamoeba histolytica. Treatment of extraintestinal amoebiasis, amoebic liver abscess. Metronidazole followed by diloxanide furoate. Abscesses require medical treatment and closed aspiration or surgical drainage. Epidemiology. Source of infection. 1. Cyst passers. Asymptomatic carriers can spread the infection. Cysts are resistant and can survive in the environment for days to weeks. 2. Food-borne transmission. Infected food handlers can contaminate food through poor hand hygiene. Contaminated food can lead to outbreaks if not properly cooked or treated. 3. Water contamination. Raw sewage contaminating water sources can lead to epidemic. Cysts are resistant to chlorine disinfection, posing a risk of waterborne transmission. 4. Use of human feces as fertilizer. Improperly treated human waste used as fertilizer can potentially spread pathogens. Proper treatment is crucial to prevent contamination. 5. Mechanical vectors. Flies and cockroaches can carry cysts from fecal matter to food or surfaces. These insects facilitate the spread of infections by depositing cysts onto surfaces or food. Prevention. Good hygiene. Drinking water from pure sources. Safe food handling and eating practices. Protect foods against fly contamination by shielding them with a cover. Dispose of all human feces in a sanitary manner. Thanks.